Hi there, it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
It's true, this is a bit of a broad talk tonight, and I do go over a little bit of things that I have spoken about in a couple of other talks, such as bunions and footwear and things like that. But I wanted to take it from a little bit of a different viewpoint to start off with first. For those of you who don't know, obviously my name's Janelle, but I am the visiting podiatrist, and I work from BJC Health, but I only work from their Parramatta rooms. So I think I'll assume that most of you are on here because you either suffer from a rheumatic condition or you maybe care for somebody who has one. And we need to know why feet are more vulnerable in these types of conditions. Unfortunately for the feet, they're considered the periphery. So the hands and the feet are peripheral to the body. And so they are furthest from vital organs, in particular the heart and the brain. So the body is very, very smart. If it needs to survive, it will keep all the blood and oxygen and nutrients and all the good stuff up around the heart and the brain and the vital organs. So unfortunately for the feet, they are furthest from the heart. And so therefore they are prone to reduced blood flow, and that can cause delayed healing, and therefore you're open to infection for a longer period of time. And unlike the hands, because hands actually suffer very similar conditions to the feet, the difference is that we don't walk on our hands, but we have to walk on our feet. And so the feet have to withstand pressure and force for us to be able to walk. The other thing that makes feet more vulnerable, because they're further from vital organs, is that they can also get reduced sensation. And some of you may already know that that's called peripheral neuropathy. And when we can't feel things enough, it means that we have a delay in detecting injury, even if that's small injuries like blisters or small infections, and also pain. As well as giving reduced sensation, peripheral neuropathy can actually give abnormally overly sensitive type sensations as well, like pins and needles and tingling and paresthesia. So it's not just rheumatic conditions who this occurs for as well. Other conditions that will really act like this for the feet are things like diabetes. Feet are also more vulnerable because of the effects of gravity. So blood gets down to the feet and fluids get down to the feet, but they have to get back up. They have to travel all the way back up to the vital organs and to the heart. And it has to do that fighting gravity. So it's got a long distance to go. It has to fight gravity to get back up and rely on those pumps within our muscles to actually get it to go back up. And when that doesn't work properly, we are prone to things like varicosities or varicose veins, peripheral edema, which is like swelling in the feet, lymphedema, things like that. Then on top of that, if you have rheumatic conditions, so I guess the distance that the feet are is more mechanical because everyone has that. But then when you have rheumatic conditions, you then have the second whammy, and that's that certain rheumatic conditions actually target the peripheries. They will target the hands and feet before other joints in the body or other parts of the body. So an example of that would be rheumatoid arthritis. In the foot, rheumatoid arthritis loves to take on the forefoot. So it likes to attack areas like your big toe joint, which is your first metatarsal phalangeal joint, create bunions in that area, toe deformities like clawed toes, and also affects the metatarsal phalangeal joints. So they're the joints underneath the ball of your foot. And you can see in some of these pictures the nodules. that's occurring, those rheumatoid type of nodules that are across the forefoot. If you have a look at both of those pictures, when you look further back in the foot, say towards the arch or the heel, it actually doesn't look as affected as what the forefoot looks. So if we look at another rheumatic condition, psoriatic arthritis, can present even a little bit more differently. It loves the interphalangeal joints. So often it will present in those very small, tiny, most distal joints, kind of almost just behind our nail plate and the one further back. So really actually in the toes and in the digits. And you can get what we call like sausage digit or dactylitis, which is intense swelling of individual toes. And then another condition, autoimmune condition, is ankylosing spondylitis. So ankylosing spondylitis is a little bit different because traditionally it tends to attack what we call the axial or the spinal and pelvic type area before it will hit the feet. And, that's not a hard and fast rule. I have had some people whose first flare for ankylosing spondylitis was actually in the foot. But by textbook, it typically, if you look at this picture to the left, you'll see there's more hot spots within that sort of upper spinal type torso region of the body and not as much in the foot. But when it does present in the foot, it likes to take on where soft tissues such as tendons or fascias like to attach onto the bone. And where that attachment point is, you can get an overpull and a flare, an inflammatory flare, and that's called enthesopathy. So where those flares are, over time, you can also grow spurring. So where the tendon or the fascia actually attaches, say, for example, in this X-ray at the back of the heel here, where the Achilles would come down, or even here underneath the heel where the plantar fascia would insert, that excessive pull and inflammatory condition over a long period of time grows spurring of the bone. So what can podiatrists do for you in this type of situation? Well, I think annual foot screening is a must for people with rheumatic conditions. So when we do an annual foot screening, or we call it a neurovascular screening, we use things like Doppler ultrasound and toe pressure cuffs to actually, so it's in this third picture here. So we're checking the blood flow from the top of your body down to the bottom of your body, all the way down to the feet. And we can even do toe cuffs to actually check the pressure of blood in, say, your big toe. We also assess sensation. Assessing sensation is how much feeling you have in your feet. When we have reduced blood flow, you will often see reduced blood flow. So patients will describe their feet have become excessively cold, excessively hot, or they might notice colour changes like red, white, or blue. But when sensation starts to decrease, it's a little bit of a silent, longer process. And often it's not until you actually have a significant loss of sensation do you actually realise that you have it. So it's something, peripheral neuropathy is something that kind of niggles away a little bit silently until it actually presents as a problem. So often I'll do testing, different types of testing with things like vibration tuning forks and monofilaments and sharp blunt and temperature and things like that. But patients are actually sometimes surprised when they fail some of those tests, because when I ask them, do you think you have any numbness in your feet? Do you have any loss of feeling? They say, no, I can feel everything. And so some of them are actually quite shocked when they fail some of those sensation tests. So they already have a level of numbness. We assess foot position. So foot position changes over time, all the way from birth to when we're elderly. And certain foot positions can make you prone to certain types of foot pain, walking problems. And so even if the foot position isn't currently causing you problems, the podiatrist can actually assess the foot position and try and tell you whether you should, try and act now and put some preventatives in place, or whether it's, actually tracking along okay. And the other thing that we assess in foot screening is footwear. Because often footwear, if it's actually causing pain or problems, maybe it's going to cause pain or problems in the future, maybe it's actually increasing your risk of falls. So they're the types of things that we can help you with. So annual foot screening, a lot of people come in with enhanced primary care plans, which if you have a rheumatic or a complex health condition, you should qualify for an enhanced primary care plan. And so even if you use one of those visits to have your annual foot screening done, some people who already know that they have peripheral arterial disease, peripheral neuropathy, poor foot position, they've already got problems in place, they often have to have more than annual, say 6 monthly, or if they've had a history of ulceration, they may even have to have their blood flow and sensation testing done monthly. But for a starting point, I would say that if you have a rheumatic condition, you should at least try and have an annual foot screening. So what are some of the common effects of altered immunity on the feet? So often when I'm at the university, I help to teach the dermatology unit. And so often we forget that the skin is the largest organ of our body. And it has such a vital role in protecting our body from infection. It does other things as well, like it regulates temperature, tells us when there's pain, but it is absolutely a shield. And when you have altered immunity, it can affect your skin and nail integrity, and that shield is broken. So it may make you more susceptible to really common type infections in the skin and the nail, like fungal infections or bacterial or viral infections, and I'll go through each of them in a moment. It can delay your healing, which can increase your chances of infection, but also ulceration as well. And of course, we know that altered immunity can cause joint and soft tissue inflammation. So I'm sure that almost everyone has had at least one bout of fungal skin infection. So a little bit of tinea in between the toes or in the arch of the foot. It can or can't be itchy sometimes. And so so when we're looking over here to my left, that would just be like a mild case of interdigital, so tinea pedis in between the toes, okay? And so usually if that was detected, if somebody knew it was there, if they washed and dried well in between their toes and they just applied, say, an antifungal cream like terbinafine once a day for 2 weeks, happy days. The superficial tinea pedis on the skin responds really well to that type of treatment. But when you have rheumatic conditions, the more simple type superficial infections can become more complicated. So you may find that the fungal infection can actually spread. So it can become quite deep. It can spread from in between the digits to underneath the ball of the foot. It can even jump to the dorsum or the top of the foot. And when it becomes more widespread like that, that is actually where topical creams and your usual treatment is probably not going to work. Unfortunately, it can also become a deeper, more serious infection in the skin. So if we have a look at this progression here, on the left, you've just started with a bit of maceration, so a bit of sweaty, wet skin in between the toes that has therefore broken the skin and is open to really common fungal infection, be it dermatophyte, be it candida, something like that, like a yeast. And what happens is when you have more complex conditions, it can actually then enter into a deeper layer of the skin, called the dermis, and the dermis is where there's blood flow and lymphatics. So what happens is, instead of the infection staying in the upper layers of the skin, it actually can jump down, enter the bloodstream, enter the lymphatics, get pumped back to the heart, and then spread through the whole body, which some of you may know as bacteremia or septicemia, becoming septic, okay? So this is the sort of progression that you get where you can see it starting to spread beyond the interdigital spaces. And then this picture to the very right is very typical of cellulitis, where it tends to be in one leg only or one leg much worse than the other. And it's a really acute onset of redness, warmth, swelling, pain, and this type of infection requires almost always IV, intravenous antibiotics, okay? Because by then, it's actually starting to pump further from the body. Other types of infections that you can become more prone to when you have rheumatic conditions, viral skin infections. So one of the most common one would be plantar warts. So the proper name for that is verrucopetus. So plantar warts are caused by the human papilloma virus, HPV virus. There are over 120 different types of HPV virus. The ones that go into the foot are only a few, and they're non-cancerous, okay? But they can be very, very painful if any of you have had plantar warts before. So plantar warts, the HPV virus, it's on both wet and dry areas, but people seem to pick it up more so in wet areas, because when we think about, like, say we go to the pool for swimming lessons or hydrotherapy or something like that, often the tiles around the wet area have a little bit of abrasion to them so that people don't slip over. And that actually harbours the virus. So the virus is actually able to attach to those tiles more easily, or say the tiles in the showering or the tiles in the wet change rooms in the gym rooms, okay? So you have to have three things to actually to actually get plantar warts. And one is that the skin actually has to have direct contact with the virus, okay? The second is that there has to be some portal of entry for the virus to sit in. And that is in areas where the skin integrity tends to be reduced. So over areas where there's pressure, so often on the heel, where there's calluses, say splits in the skin, underneath the ball of the foot, where you use a lot of pressure and a lot of friction, and you can't see, but there's little micro tears in your skin, it can easily get up into there. But the third thing is that you actually have to have lowered immunity. So for many of you, if you have rheumatic conditions, I'm sure you understand that the medications that you are on they try and lower your immune system so that your immune system stops attacking itself. Okay, but that lets more common things in. And so a simple story is heaps of kids get plantar warts, okay? So 2 out of my 3 kids had plantar warts. We were doing swimming lessons like everyone else, and they get eczema, actually, so which is probably why it entered them a little bit more easily. It didn't take my eldest child because he doesn't get eczema. He's got pretty good skin integrity. And so they had the plantar warts for 6 months. So I used the same shower as my children at home, okay? But I didn't put thongs on. I didn't do anything extra to protect my feet. So I would have had direct skin contact with the HPV virus. I had warts on my feet as a child, so I already had some level of immunity to it. I didn't have any breaks in my skin, but I am fortunate enough to not have any type of systemic immune-mediated problem. So therefore, even though I had direct skin contact and possibly could have sat on my skin or got into my skin, I don't have lowered immunity. And so that's what happens with rheumatic conditions, why you are able to contract, say, viral skin infections more easily. So how can we prevent these types of things? You need to take extra care. So one way is to look at reducing exposure of the skin, and that's to wear some form of footwear particularly if you have other household members who are using the same showers as you. Maybe they have fungal skin infections, or maybe they have plantar warts. If you're using wet areas, so shared wet areas like I spoke about at the pools and the gyms and things like that. Maybe you like to holiday, and also don't share shoes and socks. So I've just put up a few examples there. The reason I didn't put thongs up, and a lot of people, if you're safe enough wearing thongs in wet areas, then that's fine. But a lot of my patients are not stable in thongs in wet areas. They could actually probably cause themselves a nasty fall. So I tend to talk about slides that have a little bit more support coming up the foot. And I also recommend aqua shoes or neoprene shoes. And I've just given you a couple of examples there. They're really cheap. You can get them from like Big W or Kmart, and they're basically a wetsuit shoe. They can Velcro open, really easy to get on. And just when they're wet, they're a little bit more stable than a thong. But they will try and give you some skin protection when you're in wet areas, as well as a little bit more stability. Okay. Need to improve skin integrity. I think not just people with rheumatic conditions. I think the whole population is probably a little bit guilty of this, that we always say we're going to put moisturiser on our feet and we just never do. But because that shield of the skin is so much more important for people with rheumatic conditions, taking care of things like dry skin. All you need is a little flake of skin that sits up on the lower leg, and a bacteria can get in and you can get cellulitis. So taking care of things like dry skin, splits underneath, particularly on the heels and underneath the toes, taking care of calluses and open blisters. If you have an open blister, you should be keeping it clean, have an antiseptic on it, have a dressing on it until it heals. Okay. Daily inspection of the feet and between the toes. In a perfect world, if you can do that yourself, that's wonderful. But the majority of patients with rheumatic conditions often have pain in their spine, pain in their pelvis. And so actually bending down to inspect their feet daily and in between their toes is near impossible. If you live with somebody who's capable of doing that for you, that's great. If you don't, one little trick that I use is, and it's a little bit be cruel to be kind, I get patients to buy a clean spray bottle, just a small one, and I do a diluted alcohol spray. So 1/3 water and 2/3 methylated spirits. So when you use diluted alcohol and you spray it in between the toes, it's an astringent. It goes on wet, but it dries the space out, which is what you want it to do in between the toes, okay, because that's where we get sweaty and we get increases in fungal infection. However, if there is a split or a crack there and you have fairly normal sensation, it is going to sting and burn, and it's going to let you know that there's an opening down there. So like I said, it's a little bit cruel to be kind, but it's a bit like when you go to, sterilize your hands, like with, alcohol rub that we've all been doing during COVID, and you don't realize you've got a crack on your finger and it stings and burns. That's pretty much what I'm doing to the foot. So if you can't get down there and have a look yourself, just spray them with diluted alcohol. And unless you have very dense peripheral neuropathy, like very dense loss of sensation, you're going to feel it. Washing and drying feet and in between the toes. Again, it can be quite difficult for some of you to get down, but there are toe washing aids where you can use removable ends. They can be put in the washing machine. You can use one to wash in between the toes, one to dry, and they're quite long handled. And if you are, if you know you've been to shared wet areas, or your feet are particularly dirty, or your feet are particularly sweaty one day, you should probably try and use an antimicrobial wash. So an example here is MicroShield, which contains chlorhexidine. You can get other ones like Physohex, which has got triclosan in it. You shouldn't use them every day because unfortunately you can get a resistance to them if you overuse them, and they can dry out the skin too much. But like I said, on those days where you have been in shared areas or particularly sweaty, particularly dirty, or even just a couple of times a week, wash your feet well and in between your toes. This does not kill fungus and bacteria and virus. What it does is it works as an antiseptic to actually reduce the load on the foot. So reducing the risk, okay, of those and the amount of microbes on the skin.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.